Welcome back to the MedEdit podcast, your go-to space for evidence-based medical education.
And a podcast where two board-certified physicians discuss important medical topics.
Imagine a newborn who weighs barely a pound, their lungs barely ready to breathe, their heart still learning its rhythm. Every minute is a battle for survival and a miracle in motion. Welcome to the neonatal intensive care unit.
Today, we're talking about something that's near and dear to my heart for many reasons. What happens when life starts a little too soon? That's right, premature births. Babies who arrive sometimes weeks, even months before their due date. All of this is in honor of November being Prematurity Awareness Month. We are very lucky to have my good friend, Dr. Jennifer Palarczyk, a board-certified neonatologist and faculty member at UT Health San Antonio, joining us to answer our many questions today.
It's one of the most challenging beginnings in medicine, but also one of the most inspiring. Every year, millions of premature babies survive thanks to the advances in neonatal care.
We have a lot to cover, so let's get started.
Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the MedEdit podcast.
First off, we would like to welcome Dr. Palarczyk to the podcast. Welcome and thank you for joining us.
Thank you so much. It's so wonderful to be here as well.
All right, let's just start with the basics. So how do we define a premature birth or a preterm birth?
So a preterm birth is going to be any baby that is born less than 37 weeks. So starting from 36 weeks and 6 days, the baby is considered premature. We have our categories of prematurity. So usually between 34 and 36 weeks is going to be your late preterm. Between 28 and 32 weeks is going to be your very preterm, and then less than 28 weeks is going to be your extremely preterm.
So overall, premature births are common, unfortunately, and about 1 in 10 babies worldwide is born too early. That's around 15 million each year. Is this a number we have seen increasing or decreasing over the last several years?
We are seeing that increase. In 2014, the CDC had numbers of about 9.5% of premature births, and that has increased now, the latest in 2022, to about 10.4%. We are seeing that number increase. It may be a variety of reasons, both maternal and fetal.
What are some of those reasons, Jen, that you think we see that number increasing?
So I do think we are seeing mothers have births at a later age. So this is the first year, around the first year, that mothers in their 40s are actually having more births than even women in their 20s. I think that has to just do with, mostly mothers waiting a little bit longer. Maybe they're more focused on careers and things like that. Also, we are seeing increases in reproductive technologies. So IVF and things like that are becoming more prominent. And also, we have to always, have in there mothers with chronic medical problems. That may be another reason why they are having premature births as well.
Yeah, that makes sense. Especially with older moms having babies. I don't think there's any more offensive term in all of medicine than being like a geriatric pregnancy.
That's a rough one. AMA.
Yeah.
Geriatric.
No, nothing makes you feel worse than being told that. No. But, and in general, there's not a lot in medicine where we worry week to week about development. But when you're talking about premature babies, why is each week of prematurity a big deal?
The main reason why every day counts, every week counts, is because lung development really increases as the gestational age increases. So, especially alveoli development. So there's different stages of lung development. And as those weeks go by, from 24 to 25 to 26 weeks, that lung development really starts to happen during those weeks. It won't be complete until about 34 weeks, but even further on, but we kind of say that 34 weeks is at least where the lung development is starting to become more mature.
Yeah.
What do we think causes premature birth?
It's a lot of things. So obviously, if the mom goes into premature labor, one of the things that we're always very cautious to look for is infection. So is
Mm,
that the
Hmm.
body's way of expelling something that's harming not only the baby but the mother? Mothers with chronic medical conditions such as high blood pressure, diabetes, with the high blood pressure that can cause even liver or kidney problems for the mother, leading to preeclampsia. And these are things that are not only unsafe for the fetus, but also for the mother. So you do risk versus benefit of taking the fetus out, the baby out at that time, because
mhm.
we do know that the treatment for high blood pressure or pre-E is to actually get the baby out. And that will help the mother. It can be so severe that the mother can have seizures because of this. So we do take it very seriously.
And then sometimes I guess we don't know, right? And the body just goes into early labor,
I've said that multiple times. Parents have asked me,
right?
was it because I was too active yesterday? Was it because I ate something
Mm,
different? Was it because my daily activity wasn't exactly the same? Is it because I wasn't getting enough rest? And I say, absolutely not. There's nothing that sometimes parents can do, that moms can do to prevent this. Sometimes this is just what happens and it is nature, and we don't ever find out a reason why this
right.
happened.
And there's a social side of this too. Things like access to prenatal care, nutrition, stress levels can affect the risk as well. Can you expand on some of those aspects?
Yeah, so one thing that we see maybe a lot in San Antonio is that sometimes mothers are not insured, and so they
Hmm.
don't have good care prior to being pregnant. And then when they're pregnant and they're able to be insured and see a doctor, then they have a lot of comorbidities that go along with that. And so we're trying to not only help the mother with those comorbidities like diabetes, getting her glucose under control or blood pressure. But also, we do see that in the US, Black women are about 50% more likely to have premature births than other nationalities and things
Hmm.
like that.
Interesting. Yeah, we see some of that here as well, because we're kind of what they call a maternal desert in general with,
Hmm.
with prenatal care and those type of things. We get a lot of people in from New Mexico and such that also have a lack to care. So let's talk, Jen, about what happens once that premature baby is born. So they're now in the NICU, the neonatal intensive care unit. And that's going to be their home for maybe weeks, maybe for months. And it is truly an amazing place, a terrifying place,
Oh.
but an amazing place. It's full of, tiny little incubators, monitors, and of course, amazing staff. And every sound has a meaning. Every ounce is celebrated. I find this so crazy that even just 50 years ago, that babies born before 28 weeks almost had no chance of survival. That's bananas. But now, thanks to the technology and care, many of them in the US, 26 weeks of gestational age can have up to an 86% chance of surviving. That's bananas. And in the
Hmm.
Yeah.
US, it's not uncommon to hear of babies born at 22 weeks of gestational age and surviving. What do you think is one of the single greatest advancements that has made this possible over the last several decades?
I think a few things. I think number one is antenatal steroids. I
Yeah.
think giving the mom steroids before the preterm birth actually occurs is very, very valuable. The steroids are given, we hope, within 7 days of the delivery, and we hope to complete that in 2 days. So usually the mother will get one dose one day, and then 24 hours later, a second dose, and we hope to keep the baby in mom until that second dose is given.
Mm,
And it does have the biggest effect within 1 week. I think that has really helped because those steroids, they're actually helping to mature the lung faster. And that has helped not only for lung maturity, but giving antenatal steroids has decreased the risk of necrotizing enterocolitis, intraventricular hemorrhages,
yeah.
ROP, things that really used to be very detrimental. Um, Another thing is surfactant. So, if I talk to my, older colleagues that are have been around doing this for a long time, surfactant really didn't come into play until like the 80s, and so these babies were unable to get that. And surfactant is a liquid. It's given into the lungs, so we do intubate the baby for that. We put that down the endotracheal tube, and that helps to coat the lungs to help babies breathe better, to decrease what we call chronic lung disease. It helps to decrease pneumothorax, which is air filling in the pleural space. And it really helps these babies to have better development and better survival.
I truly find that surfactant supplementation to be just a really fascinating medical advancement personally. It's gone from that early trial phase in the 1950s to first successfully being used in the 1980s, kind of how you're describing, where your colleagues probably are like, what they've seen the before and after. It's pretty crazy. And now it's a standard of care. Any other advancements or things that you just, you sit there in your daily life and you're like, I am so thankful for this. And that,
one big one is the isolate. So when I actually started residency and even a little bit into fellowship, we did have isolates in our unit. Those are incubators that help to keep the baby warm. I think one great advancement too is that there are newer isolates that actually have heated humidity in them, because
oh,
baby's skin is so thin
Yeah.
that they lose a lot of water just with their skin, out of their skin. And having an isolate that is not only heated but humidified really helps these babies not only to grow because they don't lose so much water, but also helps to prevent electrolyte imbalances, which we know electrolyte imbalances can lead to things like intraventricular hemorrhages. And that's really helped a lot with that.
Yeah, that's amazing. Seeing those little babies in the incubators is always a very sad, but also a very heartwarming thing, because we know how much those little machines are doing for them. And something that I think is a super fun fact, that the first incubators used in hospitals were actually inspired by the ones used for chickens. So we
chickens.
little farm medicine crossover. And there were some early innovators, Dr. Martin Cooney being one of them, and I apologize if I mispronounced that. And they actually used to showcase these premature babies in incubators at fairs in
Oh
the
my
early
goodness.
1900s for a few reasons. One is they would raise awareness and funds for their care. He actually would set up on Coney Island, an amusement park, and parents who honestly were kind of eager just to have their baby survive would actually pay to have their baby on display, and people would pay to come view the babies, and they would use that money to kind of continue advancing these little incubators and everything else, which, I mean, it sounds shocking now, but in the early 1900s, I guess, standard of care. And I just think that's amazing.
I mean, yeah, it definitely sounds shocking by today's standards. But his work has helped, prove that premature babies can survive with the right support, obviously.
Yeah. And there's a lot of science, and there's a lot of research that goes into the science that has helped as far as for premature birth. And some of that is simple things. And I say it's the human side of it, because it's really more of that contact that we have. So I don't know if Jen probably saw this when she first started, that it was a lot, or not even when she first started, but I knew of my mom's generation, like a lot of times they would take those babies away, and like parents didn't touch them.
Oh yeah.
They weren't allowed to touch
No.
them. There was none of that or anything else. You had to, you have the little hand things in there, and like that was about it. And then skin to skin became, a big thing. And I think it's amazing that they actually did studies to show how much this helps not only babies, but also parents. So Jen, will you just tell us kind of what they consider what kangaroo care is, basically?
Yeah. Yeah. So kangaroo care is basically skin to skin. So that means putting the baby on the mother's chest or the father's chest if
Mm-hmm.
they wish to do kangaroo time too. So putting the baby on the skin of the parent. And we have seen that this actually really helps babies. You are correct in that we used to say don't touch them, leave them alone. They're
Mm-hmm.
supposed to be
Mm-hmm.
in a quiet environment, not be stimulated. There are some centers now that are actually extubating while on the mother's chest, doing
Mm.
skin to skin, and babies are found to do better. Their respirations go down, their oxygen requirement goes down, their saturations go up, their heart rate goes down, and they're much more calm. This not only helps the baby, but also the mother, because having that baby skin to skin with her helps to produce her breast milk better, and just overall bonding. It's very hard in the NICU because I can see day to day that these parents want to do something. They want to do
Yeah.
anything. And it's very hard because they feel very helpless because their baby is so small and so sick. And this is one thing that really empowers them to feel like they are really a part of their child's care, is to be able to do that skin to skin and provide breast milk.
Yeah, I agree. It's amazing that we've actually invested money and time in studying these things, because
Love
that
it.
is probably just as important as the other science that we do. And neonatal care advances
Yes.
fast.
Yes.
I mean, I swear year to year, I'm hearing about a different advancement than I've ever heard about before, and babies are surviving earlier and healthier. So let's maybe talk about some of the research that's ongoing that will likely improve outcomes for premature birth going forward. Like maybe, I don't know, if artificial wombs or any of that kind of thing.
Yeah, so artificial wombs are systems that are trying to mimic the environment of the uterus.
Hmm.
We, obviously don't have the technology right now, but that's coming. It seems like it's science fiction and something that is kind of crazy to see. But that's the goal, is for us to have an environment that would mimic whatever the baby is in the womb.
That is too cool. I mean, that'll be really, really
Yeah.
interesting. But one of the things we talked about before too, about the care before baby is born or care for moms, is that prevention care, right? We just really have to be emphasizing prevention, helping these moms and these
Right.
women who are childbearing
Right.
age to get that preventative care early.
Yeah.
Good prenatal care, managing infections and blood pressure, reducing stress, all the little things that can help prevent early births. The health of the mom, in the 12 to 36 months prior to conception are huge indicators of pregnancy outcomes. And it is kind of fun for me as a primary care physician when I have patients come in who know they want to get pregnant within the next maybe 12 months, 12 to
Mhm.
18 months. And they ask me, what can I do?
Yeah.
And a lot of the times these are the women that already are doing everything they can. But I have a couple of them sometimes that are newly diagnosed diabetics, or they're pre-diabetic. I've got blood pressure. And so we just pick apart those things, right, to kind of see how we can do better with it. But yeah, I think prevention is huge.
Yeah, I think that's definitely be the field of advancement going forward, is that if we, as we mentioned, moms being older, having chronic health conditions. And I think it is important, if you are considering, getting pregnant, it's not just right when you want to get pregnant, you start making those changes. It's literally a
Exactly.
year to 3 years before that we see the most improvement in outcomes.
Exactly. The heart and the brain are developing the earliest. That's what we're going to see. So, a lot of times, these chronic medical conditions we see have the most effect on the babies early on. We're
Hmm.
very grateful that parents find out that they're pregnant and they want to get healthy, but usually it's the brain and the heart that are already developed and can really be affected by things like high blood pressure, or especially diabetes. Diabetes and having high sugars really takes a toll and affects the baby's brain and heart development.
Yeah. And I think, prevention is going to be important. We talked about some of the other things that are coming out, but I do think one of the fields or advancements we've seen a lot, especially in, your career so far, is in nutrition, and how important the nutrition is in these premature babies. So talk to us about some of the increased use of like human milk for babies in the NICU that is now the trend.
Yes, so this is wonderful. Human milk has been studied for quite a while, and it has proven over and over again that this is the best nutrition for our premature babies. The reasons are that they tolerate human milk much better than they do formulas. Not that formulas don't have a place, but when babies are developing, the best thing for them is to give human milk. There are wonderful programs.
Hmm.
Our hospital does have this program where mothers will donate their milk. It is washed. It is, monitored for any infection, and it is donated breast milk. So this is for mothers that are unable to give their child breast milk. We have the option of giving that donated breast milk so that every baby born premature can start off life with using only human milk. We also have technology now that we know that human milk, although be it wonderful and the best for our babies, may not be enough as far as calories or things
Hmm.
like calcium and phosphorus for babies to have adequate growth. So we also have a fortification that is also made of all human milk. So every baby that is born extremely premature will not only get nutrition from the breast milk, but also fortification from that as well. And we have seen that babies are off of parenteral nutrition, which is nutrition through an IV. They are growing much better. They are tolerating this much better. And it really has done wonders for these babies' survival as well.
Amazing.
That's great. I know the donor breast milk is always very highly appreciated in these NICUs for sure. Because it's hard, like you said, for mom to be stressed about everything else in the NICU and then be stressed that she can't make any breast milk either. It's really hard.
And we're feeding babies much earlier too.
Right.
So I think it used to be don't feed, just let them on the nutrition through the IV. And now it's feed, use that gut as quickly as we can, because we know that there are side effects to leaving babies on IV nutrition.
Yeah, absolutely. And an important question I know from my own personal experience and just in general that comes up a lot is, what about when babies are ready to go home? You know, what is their life potentially going to look like for these parents?
You know, I think every baby is a little bit different, and what their, journey has been in the NICU and what their journey will continue to be at home. Some of these babies, they may need to go home on oxygen because maybe their lung disease was just too progressive and that we aren't able to safely send them home without oxygen. Some babies, may need a G tube, which, is for feeding because they can't get all of their calories through mouth. But I would say, they do have a lot of follow-ups. We are very careful to have them follow up with our preemie clinic, neurodevelopmental specialists, early childhood interventions, and then all the subspecialists that help us in the NICU, they'll continue to follow. So I think, for every parent, this journey is a little bit different, but getting these babies discharged, getting them home, getting them the resources that they need when they're home really does help their neurodevelopmental outcomes.
These poor babies. They have to go through so much. What are some of the long-term risks of prematurity? People always worry, okay, they survived the NICU, they're home. What happens to them as they get older?
Yeah. So, the things that we're looking out for, obviously, with every single baby that is born extremely premature, are a few things. We're looking at their brains. We do head ultrasounds, which are ultrasounds of the brain to check for any bleeding. This happens because babies' vessels in their brain are just not fully developed. And so we can have what's called intraventricular hemorrhages, which are hemorrhages that are inside or sometimes outside of the ventricles. So we watch that very carefully. We do multiple surveillance head ultrasounds on babies. If the head ultrasounds become concerning, then they may need a shunt to help relieve that pressure so that the brain can grow. We don't want the ventricles to get so big that the brain matter is unable to grow. We're also watching their eyes very closely. So, ophthalmologist that is trained in retinal specialty will come and they'll look at the blood vessels in the eyes to make sure that these don't grow too quickly, because that can cause retinal detachment and blindness. We're also, with our colleagues, pulmonology, making sure that babies, if they do need to go home on oxygen, are being cared for, and watching out for any, infection, because they're going to be more prone to viruses, RSV especially. If babies get that and they have lung disease, sometimes don't tolerate it as well and need to go to the hospital for extra support. We're making sure that they're tolerating their feeds and they don't have any signs of infection in their gut. Usually by the time they're ready to go home, they do very well, and they're on whatever they're going to be at home, whether that's continued with the breast milk or need to transition to a preterm formula. So we're watching out for tolerance, and then making sure that they're getting all their calories that they need through mouth, and they don't need any other special things like an NG to go home or a G tube.
Yeah. And I think in general, it's probably like the more premature you are, the more risk of these things that you're having. So it's kind of correlates
Exactly.
with that as far as for what the risk are long term, right?
Exactly. If you're born at 24 weeks, that's much different than born at 34 weeks. At 34 weeks, usually babies go home within 2 to 3 weeks if the
Hmm.
course was pretty benign and, the usual course, and they don't need much support or help, and they just get followed up with their primary care physician, and they continue to get monitored that way, and they don't also you always need any like subspecialists or extra help. We do say though that once the baby goes home, you have to make sure that you're treating the baby not like a full term baby. So a baby born at
Mm.
34 weeks, they're going to be behind about 2 months, 6 weeks to 2 months. So things that, you might have seen your other child do at 2 months, your baby, if born prematurely, might need another couple of months to catch up, and that's okay. That's okay.
Yeah.
They'll get there, but not to worry and push too hard, because these babies do need extra time to get to their milestones.
That's a really good fact to point out, obviously. Yeah.
Yeah. Cause it's going to be scary when you go home if you don't know that and you're talking to your pediatrician. And again, if you have other children who met those milestones,
Yes.
that it is going to be as
Right.
if they were born premature, basically. So they're not going to be, they would have been inside the womb a little bit longer
Yeah.
developing. So, well, we know that premature
Exactly.
birth is one of the
Yeah.
toughest challenges in medicine, but it's also one of the greatest success stories. And I think a lot of times it's just a proof of how far medicine has come in a lot of ways. From makeshift incubators at an amusement park to cutting edge neonatal units that save lives every day. Behind all these statistics, we have the family. Of course, it's super important. We have incredible teams of doctors and nurses and everyone else. And in general, I always find it amazing to see a lot of these babies afterwards, years afterwards. And a lot of them, you would never even know they had such a rough start in life. So I think that that's what's
Right.
so incredible is they are so resilient. It's so impressive. But thank you so much for what you do. And thank you for joining us as our expert, Dr. Palarczyk. We loved having you.
Thank you so much. This was wonderful.
We love it. So, just for our listeners as well, if you'd like to learn more or support families with premature babies, check out organizations like the March of Dimes or your local NICU charity. Well, that wraps up today's episode of the MedEdit podcast. If you're a clinician, check out those show notes to claim your CME credit.
And if you're already following us on social media, reach out at the MedEdit podcast and let us know what medical topics you'd like for us to cover next.
Thank you for listening to the MedEdit podcast. Please click the follow button to be notified when more episodes become available. For more information about this episode and to find out how you can reach Dr. Cari Sorrell and Dr. Jessica Gray, please visit today's show notes. Be sure to follow us on our socials, Facebook, Instagram, and TikTok to stay up to date on all things the MedEdit podcast. The information and content has been made available for informational and educational purposes only and does not constitute a physician-patient relationship. If you need medical advice or help, please contact your personal physician. The views and opinions of the guests do not necessarily reflect the views of Dr. Jessica Gray or Dr. Cari Sorrell. This podcast should not be considered an alternative to medical advice or diagnosis or confirmation of an illness or disease. Please seek help from your personal care practitioner. Thank you for listening, and tune in next time.